Hey everybody, this is Eric with FlightBridgeED. Welcome back. Today I thought we could do a podcast on pressure control ventilation or pressure-driven modes of ventilation specifically. I know I have done podcasts, three-part podcasts on ventilator management, and we went through every mode of ventilation as it relates to EMS and pre-hospital settings. I know there's other modes of ventilation that are used in the ICU setting that we probably wouldn't utilize and that I haven't gone over. I just got done doing some training for my primary role as an educator with the company I work for, and one of the areas that I saw people needing more understanding of is pressure-driven modes. It's very easy to understand volume modes, very easy to see how that works and understand the pathophysiology as it relates to that. But when you get into pressure-driven modes, it's a little bit more complex, and it seems like there's some confusion. So I thought I'd spend maybe 20-25 minutes and just go over specific aspects of pressure-driven modes and how they can positively affect our patients. Like with any podcast, I want to start out with a quick scenario. We'll set the tone for the podcast. I'll hopefully answer some questions. And this scenario I give you is going to be a very complex ICU patient. So there's going to be different aspects of this, and maybe this will branch off, and I'll do some other podcasts with other aspects of this scenario. You're dispatched to a transfer for a small rural hospital. You have a 50-year-old male with H1N1. If you remember a couple years ago, that was a pretty prevalent thing. A lot of people were getting diagnosed with this disease process. He has sepsis and associated ARDS. He is currently intubated and on the ventilator. No report really was given from the RN. They seemed very busy. And when you arrive at the patient's bedside, your current ventilator settings, he's in a CMV mode, so that's a control mandatory ventilation mode. If you remember from my earlier podcast, I'm not a very big advocate for that mode of ventilation. He's at a tidal volume of 600. He's at a respiratory rate of 12. He has an FiO2 of 40%, and he has a PEEP of 10. His current plateau pressure is 38 millimeters of mercury. His vital signs at this point are BP of 76/40. His heart rate is 130, and his O2 saturation is 71%. You ask for a current set of ABGs, and this is what you have. You have a pH of 7.10, you have a PaCO2 of 60, you have a bicarb of 16, and you have a PaO2 of 40. So there's different aspects of this scenario that should ring out to you. If you're new to ventilator management, if you're new to this industry, critical care-wise, if you're a new medic that's wanting to transition, this is a very complex case. If you're an RN that's worked the ICU, you see this all the time. So some different aspects of this. First thing that we should see is he's on a controlled mandatory ventilation mode. That's a very poor mode of ventilation because it doesn't allow the patient any effort to breathe on their own. They can't initiate their own breath. Their sedation has to be perfect. They have to be paralyzed. And, a lot of times that's not the best thing. He's tidal volume, I believe we'll say his weight is 80 kilograms, so his tidal volume is a little bit high. If you remember from my podcast on ventilator management, the three-part series, there's an obstruction approach and there's an injury approach. And being that he has ARDS, this would be an injury approach. The injury approach, the protective mechanism of that approach is the tidal volume. We want lower tidal volumes to protect that weak, fragile baby lung. So his tidal volumes are 600. His respiratory rate is 12, so that's low. So we're kind of opposite of what we should be. We have a higher tidal volume, we have a lower respiratory rate. His FiO2 is 40%, and his PEEP is 10. His plateau pressure of 38 millimeters of mercury. And if you remember right, that is the most important thing we should look at on all our ventilator patients is our plateau pressure, because that tells us what our alveolar health is. What's going on at the alveolar level? What are they seeing pressure-wise? And we know that anything greater than 30 is going to cause potential for barotrauma, atelectasis trauma, and it causes shunt and VQ mismatch. And so we don't want a plateau pressure excessively high. So we need to always be thinking about how we can correct that and lower that down. He obviously has other issues as well. He's hemodynamically unstable. His heart rate, he's tachycardic, and his O2 saturation is in the toilet. He's on a ventilator. His O2 sat is 71%. And if you look at his ABGs, they're horrible. He's got a pH of 7.10, so he's acidotic. He's got a PaCO2 of 60, okay? So he's acidotic there, and he has a bicarb of 16. And so he's acidotic there. So that's what's called a mixed disturbance. He has a metabolic, respiratory, and metabolic acidosis, essentially, with profound hypoxia as well, because his PO2 is 40. All right, so how are we going to manage this patient? Why is his pH low? Why is his CO2 so high? Well, I can bet you that he's probably, number one, trying to breathe over the ventilator. And the ventilator is just slamming that breath in. His sedation is probably poor. A lot of times sedation is poor when blood pressure is low like that. A lot of times caregivers or even physicians, they, in these smaller facilities, they don't understand or they don't see the need to give sedation and pain management. And if you listen to my podcast on pain management and sedation, the research is now going to heavy pain management with fentanyl drips, fentanyl boluses over any type of benzodiazepines at all. Research has shown that benzodiazepines increase patient stay in the ICU. They're on the ventilator longer. So obviously we want to reduce that time. So how are we going to manage this patient? Well, there's a few things we got to look at here. Number one, we first need to change modes of ventilation. And we know that CMV is not a good mode. So what mode do we want to go to? Well, when you have a volume mode like this is a volume-driven mode, we have other issues, right? We have a plateau pressure of 38 millimeters of mercury. So how are we going to correct that plateau pressure? That's our number one thing. Even though he's in a mode of ventilation that's poor, we've got to correct that plateau pressure. So let's try to do that. The first thing we do, if you remember my other podcast, is we've got to reduce that tidal volume. We already know that tidal volume's high, okay? The tidal volume's high, so if we remember correctly, the tidal volume range for injury, an injured lung in the injury strategy is anywhere from 4 to 6 mils per kilogram. So if we have an 80 kilogram patient and we start at 6 mils per kilogram, that's 480 on the tidal volume. That's the beginning spot where we want to start with. All right, so I would immediately drop his tidal volume to 480 and see what our plateau pressure is. Check another plateau pressure, and if you remember correctly, our plateau pressure is checked on ventilators by doing an inspiratory hold. We do a half-second inspiratory hold. It holds that breath. The pressure, when it plateaus and comes down after the exhalation process, it holds it, and it gives you a pressure reading at the alveolar level. All right, so that's our first step. We need to reduce the tidal volume and recheck it. Remember, any volume you put into a container, if the volume is more, it's going to exert more pressure. So if you reduce that volume, the pressure is going to be reduced, accordingly. If the plateau pressure in this patient doesn't improve by reducing the tidal volume, we're going to go down to 5 mils per kilogram. Remember, our range is 4 to 6 mils per kilogram on our tidal volume. So we would go down to 5 mils per kilogram on an 80 kilogram patient. That's going to be 400 on your tidal volume. And we're going to keep doing that until we get down to the 4 mils per kilogram. We want to stop there because we don't want to affect minute ventilation. Remember, minute ventilation is everything when we talk about ventilator management. It's right up there with plateau pressure. We have to have a good minute ventilation, an adequate minute ventilation to maintain eucapnia. We've got to have a good end-tidal CO2 range. We already see that his end-tidal CO2, or I should say his PaCO2 on his blood gas is high. So he's already retaining, he's already trapping CO2. He may be having auto-PEEP because of the mode of ventilation he's in. All right, so I'm taking you kind of down a road here. We have identified his plateau pressure is high. We've identified that his mode of ventilation is the wrong mode of ventilation for this presentation. We've recognized his tidal volume is too high. We've changed the tidal volume and reduced that down from 600. We started at 480. We're at 400 now, and we're going to go down to the 4 mils per kilogram, which would be a 320 tidal volume. Okay. At this point, if you do not have a reduction in plateau pressure, and I can probably assure you based on ARDS presentation and the amount of fluid and inflammatory cascade that's surrounding those alveoli, you're probably not going to have a reduction in plateau pressure. So what do you do at this point? Well, the step number 2 in any plateau pressure that's greater than 30 is you got to identify what's causing it, right? So we know that it's probably ARDS. In a trauma patient, it could be a tension pneumothorax. So we could correct that immediately with chest decompression. In this patient, ARDS, we're not going to be able to correct this overnight. We've got to do good ventilator management to correct this problem, along with good management of his sepsis and his underlying illness. All right, so the third thing we do is we need to switch to a mode of ventilation that's going to be very gentle on the lungs and the alveoli, and that's pressure control ventilation. So that's where we get into the pressure regulated modes of ventilation. He initially was on volume control. That's not working. We're going to switch to pressure control. All right, so that's what we're going to do, and I'm going to start off and I'm going to start talking about pressure control ventilation. This is an excellent mode of ventilation for any patient that has a weak or fragile lung, a baby lung. So if you really look at the groups of patients that we fly or we transfer from ICUs, you could probably categorize 7, 8 out of 10 patients with this etiology. Everybody has some type of lung disease, or they're injured because of trauma, pneumonia, bronchitis, COPD, etc. When we see these types of patients, we need to manage them accordingly. And what I see in my training through the industry is that this mode of ventilation is not very comfortable. People aren't comfortable with this mode of ventilation. But really, guys, this is what they need to be on. All right? Not only do these sick adult patients with these different lung etiologies and presentations, but all pediatric patients need to be on a pressure-driven mode of ventilation, whether it's pressure control ventilation or pressure-regulated volume control ventilation, which we'll get to next. All right, so what's the difference between pressure control ventilation? Well, this mode of ventilation is based on compliance. All right, so we know that with any lung disease or injury or inflammatory cascade, compliance of the lung, how sick that lung is, can be different with every patient, and our compliance is different, right? If we put a BVM on a patient and we checked and squeezed that BVM, every patient's going to be a little bit different. And if you kind of use the trauma patient, because this is a good way to explain it, and you have a simple pneumothorax, and your BVM is normal, right? You're squeezing the bag and you got good compliance. And as that pneumothorax increases, the BVM is going to be harder and harder to squeeze because the lung is being pressed against. There's air in that lung cavity, in the chest cavity, that's compressing the lung, and you can't put pressure or volume into that lung. Well, pressure control ventilation is a mode of ventilation that's based on compliance. It's constantly it's not going to overextend that lung. It's not going to cause ventilator lung injury, and it's very good in those types of patients. That's why it's so excellent for pediatric patients. We know when we learn this in EMT Basic or when you're first starting nursing school, pediatric patients are very susceptible to barotrauma, and so this mode of ventilation is very gentle for those types of patients. All right, so what's the difference here? Well, you have a tidal volume you're going to set. You're going to set a respiratory rate, and you can add pressure support. Remember, pressure support is an augmentation to ventilation. So in assist control, SIMV, and in pressure control ventilation, patients can initiate their own breaths. In SIMV and in pressure control ventilation, though, you can add what's called pressure support, and that's an augmentation mode where you have a pressure that's at the end of the circuit, and when the patient initiates their own breath, based on the trigger that you set, it will help them take that breath. It kind of just turbo boost. It's like a turbo boost to help them deliver the breath, so it reduces the workload on them. All right? So here's the thing about pressure control ventilation that kind of gets people, is when you set the tidal volume is not based on a volume. It's set off of an inspiratory pressure, all right? And so on your ventilators, when you set in a volume mode, you're setting a tidal volume and you're setting a respiratory rate. In this pressure control ventilation, you're not doing that. You're setting an inspiratory pressure. That inspiratory pressure is going to deliver a pressure that's going to give you a certain volume, if that makes sense. So for instance, on the LTV 1200 ventilator, you would push inspiratory pressure. It's going to default to 20 millimeters of mercury. That 20 millimeters of mercury is going to give you a tidal volume. And that tidal volume could be different for every patient because remember, it's based on compliance. Okay, so for a pediatric patient, a pressure of 20 could give you a tidal volume of 200. So from what I've seen in my treatment of patients in this mode of ventilation, it defaults at 20. For an adult patient, you're probably going to turn it up to 25 to 30. And what you're going to do is you're going to move your settings button on your ventilator to exhale tidal volume, and the abbreviation for that is capital V as in Victor, lowercase t, lowercase e as in Edward. All right, and that is going to give you a exhale tidal volume. Okay, so you're going to set a pressure, let's say of 30. You're going to let that cycle through, and you're going to see what exhale tidal volume number you get, and that's how you're going to titrate your tidal volume. You're not going to be able to set a desired perfect tidal volume with a button like you would in a volume mode of ventilation. All right, so you're going to set the pressure at 30. You're going to look at your exhale tidal volume, and if you desired a tidal volume of 500, you're going to titrate that pressure number to give you the desired tidal volume you want. If you put it at 30 and your exhale tidal volume for that patient is only giving you a 450, and you were hoping for a 500 tidal volume, then you would turn that pressure up a couple points, 1 or 2 points. Turn it up to 31 or 32 and see what that gives you. And you're constantly going to be doing that. The thing with pressure control ventilation is that, again, it's based on compliance. And when you talk about volume modes of ventilation, you get what is called a guaranteed minute ventilation. You set a tidal volume, you set a respiratory rate, and that gives you a minute ventilation. So if you had a tidal volume of 500, you had a respiratory rate of 20, that's going to give you a 10 liter a minute ventilation, and that's going to be guaranteed every time. With pressure control ventilation, you set your respiratory rate, but remember your tidal volume is based on a pressure which is based on compliance. So if your compliance increases, it gets better, then your tidal volume will increase. If your compliance decreases, like in a tension pneumothorax or something like that, then your compliance decreases and your tidal volume will decrease accordingly. So the thing with this type of mode of ventilation is the clinician has to watch their patient very closely, because if your compliance gets worse, if you start having problems like with a trauma patient and you start tensioning, your compliance gets worse, your minute ventilation is going to decrease, and you'll see an accordingly increase in your end-tidal CO2. You're hypoventilating your patient, okay? So advantages to pressure control ventilation. It's excellent for increasing oxygenation in challenging patients such as ARDS, chest trauma, and children. All right, why is that? Well, with any pressure that we give, what that does is that decreases, it's called decelerating flow pattern, okay? And what I mean by that is, if in a volume mode of ventilation, if you give a breath and you allow the patient to exhale, the exhalation process is always going to be longer than the inhalation process, right? And if you remember my podcast from before on ventilator management, that's an important thing to understand, that our inspiratory process is a very easy process. We don't have to really think about that. That's where diffusion happens, and the exhalation process is an active process. We have to work a little bit to exhale. All right, so in these types of patients with pressure control ventilation, you have decelerating flow patterns, and basically what that means is your inspiratory process is constant, right? It's a little bit easier for them to oxygenate, so that's why it causes increased oxygenation. It decreases plateau pressures, okay? And so one thing about plateau pressures in pressure control ventilation, basically the pressure that you're giving to elicit that volume that you want, that tidal volume you want, that's now essentially their plateau pressure. So if you set a volume or a pressure of 25 on your ventilator to get whatever tidal volume you want. That is essentially now the pressure that the alveoli are seeing. It reduces plateau pressure, okay? And then any patient with possible compliance problems, COPD patients, asthma patients, ARDS patients, pneumonia patients. I mean, I could go on and on and on where we should be using this mode of ventilation for our sick patients. Obviously, with any mode of ventilation, there's some disadvantages. It can be uncomfortable, especially if you get into some advanced procedures like inverse ID ratios. And to kind of give you an example of an inverse ID ratio in ARDS patients, if you set your inspiratory time on your ID ratio longer than your expiratory time, it's the same philosophy as that decelerating flow pattern. We've got a longer inspiratory time. Remember from my other podcast, the inspiratory maneuvers that we do, that's what recruits alveoli, right? PEEP maintains that recruitment. So good aggressive inspiratory maneuvers recruits alveoli. PEEP maintains that recruitment. Pressure control ventilation, you're going to need to sedate and manage your patients with analgesia very aggressively. It can be uncomfortable. Any mode of ventilation, guys, is uncomfortable for our patients. That is not how we breathe physiologically. So be very kind to our patients. Remember, listen to my pain management and sedation podcast. Pain management is number 1. Sedation is number 2. Research has shown that patients stay on the ventilator longer when you're using a lot of sedative medications, benzodiazepines, Versed, Valium. We need to be giving more pain management. And the lastly thing is we have to watch our patients very closely. You do not have a guaranteed minute ventilation due to the tidal volume based on compliance, okay? So those are the advantages and disadvantages of pressure control ventilation. So again, to recap that, we're gonna look at our plateau pressure. If we have a high plateau pressure and we're worried about compliance, we can't reduce that plateau pressure by reducing our tidal volume or by correcting it with some type of treatment. Then we're going to switch to a pressure mode of ventilation, and that would be pressure control ventilation. The big thing to remember with this mode of ventilation is it's compliance based. You don't have a guaranteed minute ventilation, and that your pressure that you give, that's what elicits the tidal volume that you get based on exhale tidal volume. Now I'm going to put different things in the forums page. It'll be under FlightBridge Podcast documents and attachments, and I'll put some different literature, pictures, and things like that on this mode of ventilation for you guys to refer to if you'd like. The second mode of ventilation as it relates to pressure is what's called pressure regulated volume control. And now this mode of ventilation is an excellent mode of ventilation for children. This is the new standard for children. It's a form of assist control. Okay, so if you remember from the earlier podcast on ventilator management, the assist control is a mode of ventilation that gives you the ability for the patient to initiate their own breath. The ventilator senses that and delivers a breath. It won't let the patient take that breath, but it does sense that the patient wants to take a breath, and it will deliver the breath that they're desiring. But the breath is going to be given based on the tidal volume that you have set for them. The other aspect of this pressure regulated volume control is that the ventilator will initiate controlled breaths. So you set a respiratory rate of 10, it's going to give 10 breaths. With the aspect of assist control, the patient can initiate their own breaths. And this mode of ventilation kind of goes a little further, and it allows the patient to take that breath. Okay, let's give a respiratory rate of 20 for a kid. And you set the respiratory rate at 20, and the kid wants to take 10 breaths per minute. The ventilator is going to let that kid take 10 breaths per minute. It's going to recognize that, and it's going to deliver 10 more breaths to get the equal 20 breaths. So it's very good. It's very comfortable for the patient. The other great aspect of this mode of ventilation is it gives a constant pressure throughout the inspiratory phase, like pressure control, regardless of whether the breath is controlled or assisted. All right? So controlled would be the ventilator's giving the breath. Assisted would mean that the patient is getting the breath. So that's that decelerating flow pattern that I talked about before. Better inspiratory recruitment measures. And this gives you increased oxygenation. So that's excellent. The thing about this mode of ventilation that pressure control doesn't have is this gives you a guaranteed minute ventilation. And I'm going to explain how it does that. So this is what the ventilator does. The ventilator is going to give a test breath, okay? And it essentially checks a plateau pressure. You set a tidal volume of, let's say, 200. You set a respiratory rate of 20. The ventilator does a test breath. It measures the tidal volume. And again, we're measuring against compliance. What is the ventilator sensing the compliance of the lung is? All right? It compares to the set tidal volume that you have. If the tidal volume that it delivers or it senses is more than what you have set in the ventilator, so if it's greater than 200, then it's going to decrease the pressure to deliver that breath. All right? So this is basically what's called volume targeted pressure delivered or pressure regulated. What I mean by that is it's going to be delivering a certain tidal volume based on the ventilator's understanding of the lungs' compliance, and it's going to adjust the pressure to deliver that breath based on compliance. Okay? And I'll put this chart on the documents and attachments under the forums page under podcast, and I think it'll be very easy to understand. If the ventilator senses that the tidal volume is equal to what you've set, then it doesn't change the pressure. Again, if it compares the tidal volume and the amount of tidal volume it delivers is less than what you set, then what it does is it increases the inspiratory pressure to try to bring up that tidal volume. The thing about this is that's so excellent is it constantly is looking at lung compliance, and it's adjusting the pressure to try to deliver a guaranteed minute ventilation. So that's what's so excellent about it. In this mode of ventilation, you still need to set an ID ratio. Right? Remember, your ID ratio is your inspiratory and expiratory time. Very important. This mode of ventilation is obviously the go-to for children, so we have to lengthen our ID ratio out, 1 to 4, 1 to 5. Remember, with anybody with a longer respiratory rate, greater respiratory rate, 20s to 30s, you have a lower expiratory phase. So we have to lengthen that out to allow them to blow off that CO2. You don't want gas trapping and air trapping. That causes auto PEEP. It decreases compliance. It increases plateau pressure, and it's very, very poor for our patients. So the other aspect of this mode of ventilation is again, how does this relate to plateau pressure? All right, and what you do is you set a upper pressure limit alarm. All ventilators have low pressure alarms. They have high pressure alarms. They have high minute ventilation alarms and low minute ventilation alarms. And with this mode of ventilation, what you need to do is you set a upper pressure alarm. And we're going to set that about 35 millimeters of water, or centimeters of water. And that's basically a little bit above what our plateau pressure should be. Okay? You're going to, your ventilator is going to deliver the tidal volume, and it's never going to go above that pressure limit. So if you set it, let's say that pressure limit of 30, it's only going to exceed that by 5 centimeters of water. It's never going to go above, so it's very safe. You're basically setting pressure limit so we don't exceed and cause barotrauma and increased pressure against the alveoli. So you're basically protecting the lung based on plateau pressure. You're going to still set an ID ratio. Again, you're going to set your FiO2. And that can be based on 100%, or you should titrate that down, obviously. And you're again going to set a PEEP. A good starting PEEP is 5 centimeters of water. Remember, intrinsic PEEP is anywhere from 3 to 5 centimeters of water. This patient is an injury lung approach, so PEEP is going to be good. We need to maintain that alveolar recruitment that we've worked so hard for with these aggressive inspiratory maneuvers, and maintain that recruitment with good PEEP and management. Obviously, we need to go over advantages and disadvantages. Advantages, obviously, this is excellent mode of ventilation for kids. You get a guaranteed tidal volume. You get a guaranteed respiratory rate. Whether the patient initiates their own breath or not, it's always going to deliver a guaranteed minute ventilation. You have a very low risk for barotrauma. You have that decelerating flow pattern that provides excellent oxygenation, and it's very gentle on the lungs. Obviously, there's some disadvantages. Could be potentially increased pressure too high. So if you remember with that chart that I read off, if the ventilator keeps trying to increase the pressure to maintain a good tidal volume, to maintain that minute ventilation, we can have pressures too high. So we have to still watch our patients. We need to be have an understanding of the pathophysiology as it relates to the lung disease or the presentation, and kind of foresee problems, right? You can have variable tidal volumes. Obviously, if it's constantly fluctuating the pressure to deliver a certain tidal volume, the ventilator can get a little off and you can have some fluctuation on your tidal volumes. But for the most part, this mode of ventilation is very safe. It's excellent with anything that we do treatment-wise in medicine. There's obviously risk factors, but this mode of ventilation is excellent. So if we go back to our presentation, if we go back to our scenario on this patient as it relates to ARDS, what are we going to do? Well, we're going to switch to pressure control ventilation. Okay, this is an adult patient. We're going to lower that tidal volume. We're going to use that lung protective strategy. We're going to lower it probably to the 400, 480 range. We're going to increase that respiratory rate. We want to maintain eucapnia. We want to try to affect change with our end-tidal CO2 and our PaCO2. We're going to increase FiO2. He has a PaO2 of 40. He's hypoxic. At this point, we need to increase that up until we can hopefully correct that. Remember, his O2 saturation is 71%. All right, and what about his PEEP? Right, we got good recruitment. We're going to try to recruit more alveoli with good pressure control ventilation management. But what are we going to do with PEEP? Remember, with ARDS, we have just floods of nasty stuff that fills up these alveoli. We have massive shunt. And if you remember from my podcast on ventilator management, part 1, I talk about alveolar membrane and picturing that as a big glass window or a big glass door. And if you imagine if you took a big old thing of mayonnaise and you wiped mayonnaise over the center of it, right? Maybe a big circle. Well, imagine that's shunt. That is what a shunt is. So if we somehow were able to make that glass door bigger, that would reduce the shunt. So that's exactly what PEEP does, right? PEEP helps do that. We have good inspiratory maneuvers with our pressure control ventilation, and we need to maintain that with good PEEP. So in this setting, this patient would really benefit from higher PEEPs, right? We want to increase that surface area in the lungs. We want to increase what's called functional residual capacity, and we want to really optimize oxygenation in that way. Hopefully, based on the pressure control ventilation, with lowering the tidal volume down, increasing the respiratory rate, will have a direct effect on the plateau pressure. This probably won't happen immediately, but you should start seeing this trend down. And hopefully, if you have good maneuvers oxygenation-wise, remember oxygenation drives cardiac output, and that's the whole philosophy of the Fick principle. So hopefully, we probably, with a sepsis patient, he's probably dry. We need to be giving him a lot of fluid. Sepsis patients need 5, 8, 10 liters of fluid a day. If you refer back to my podcast on fluid resuscitation, different types of fluids and how they affect the patient. So I'm not going to get into that right now. But giving this patient a lot of fluids and maybe starting them on a aggressive pressor like neosynephrine that doesn't have the heart rate effects because he's already tachycardic, causes systemic squeeze, alpha effects, that would be probably a great thing. So that's another aspect here. We got PEEP. We need to increase the PEEP, but one of the contraindications of increased PEEP is hemodynamic instability or hypotension. So remember, we want to keep a MAP pressure at 60 to 65. That MAP pressure of 60 to 65 is going to give you a good cerebral perfusion pressure, and that's all we need, right? So what's going to fix this patient is increasing the oxygenation, fixing that oxygenation status, and hopefully by doing that, you're going to correct the blood pressure. I'm going to leave you with this. Obviously, the ABGs are kind of out of whack. The next podcast I do, we're going to talk about ABGs, how to affect change in our pH based on our bicarb, based on our end-tidal CO2 and our PaCO2, and kind of understand the different aspects of labs that we need to be looking at in a transfer situation and how we can affect change and clinical outcomes with our treatment. So I just want to thank you. Again, I'll put all these different things in the forums page under FlightBridge Podcast, documents and attachments. And if you have any comments, questions, anything, shoot me an email at eric@flightbridgeed.com, And we'd love to hear your comments, new ideas for topics. And we'll talk to you soon. Thank you.